who is a faculty of national repute. He has done MBBS from JJM Medical College, Davangere, Karnataka. He has secured first rank in MD entrance exam of Manipal University and obtained MD in radiology from Kasturba Hospital, Manipal. He has completed visiting fellowship from Harvard University in neuroimaging. He has obtained European Diploma in Radiology along with Diplomate of ICRI in November 2019. He has won multiple prizes during post-graduation in quiz programs. He is a prolific researcher with more than 100 publications in national, international index journals till date. He has contributed for 3 textbook chapters. He has presented in various state and national conferences. He is a reviewer for 3 index journals, including PubMed Index Journal of Neuroscience in Rural Practice. He has presented one national educational exhibit in RSNA 2015 Chicago and educational exhibit in Austria, Vienna 2020. He is APIRIA Secretary 2025 to 27 and Scientific Coordinator APIRIA 2025 to 27. He is AOSR National MR Safety Liaison and ICRI Abdominal Imaging Coordinator 2024 to 2025. He is the editor of YouTube channel Radiology Case Videos, which all of you can subscribe. His fields of interest are MSK imaging and neuroimaging. So this session is a great opportunity to test your knowledge, learn key imaging pearls, and sharpen your spotter skills. Let's get started. Over to you, Dr. Reddy.
Thank you very much, Dr. Geetanjali.
Thank you, sir. So before starting, I will just brief the candidates about the rules. So students, there will be around 12 sets of spotters with 10 spotters in each set. And sir will flash the spotters one by one. There will be a gap of around 20 seconds between the consecutive spotters. So all of you can write the spotters on a piece of paper. And after the 10th spotter, sir will tell the explanation of the spotters. So I think we can begin. Over to you, sir.
Thank you. Thank you very much. First of all, I would like to thank Sachendra for doing wonderful job for Indian academics in radiology. And he is always a dear friend of mine. As soon as he asked me to deliver this lecture, and had no second thought. Next, Dr. Geetanjali for taking so much of time in reading everything. And thanks for that. And Kapil, for your great teaching skills, I bow down. Keep doing the wonderful work. Anytime for academics, I'm there. So let us directly go. And I congratulate the students for joining this platform. Like it's going to be a really great platform for you to learn. All these people are wonderful teachers. In fact, I am not sure that how many of you read this radiology with TS. I would have definitely read it once or twice, even after I finished my MD, post-MD to brush up for a few exams. Really great job, guys. Okay, let me directly go to my spotters. Please, everybody write it down so that it will be more engaging. And I'll be very happy to see you answering in the chat box. So these are the 2 things I request from you. Yeah, let me start. Spotter 1. Spotter 2. Yeah. The number is in this corner. Hello, sir. Hello. సార్ అట్లేదు సార్, అవును సార్, చేసి చెప్తాను. నేను అదే సార్, నేను కాల్ చేస్తాను సార్, కొద్దిసేపులో క్లాస్లో ఉన్నాను. నేను ఆయనతో కూడా మాట్లాడి మీకు కాల్ చేస్తాను మళ్ళీ. బాయ్ బాయ్. Sorry for that. There are 3 images in this. You can take 10 more seconds. Hello. Yeah. Okay. Let's discuss these spotters. So these are the answers. I'm audible, guys? Yeah. Chart
Yes, sir,
box.
audible, sir.
Yeah. So the first one was a simple chart box. You can shoot. This is the case of scleroderma. Okay. So what we can generally see that the barium is showing the fatless GE junction, and you can see the acroastolysis in this case. Classical acroastolysis. Here you are able to appreciate the acroastolysis and also deformities. If you carefully observe here, there is some degree of calcinosis. So all these features, fatless GE junction. So this falls into a CREST syndrome. So acroastolysis, periosteal osteopenia, and you can see rheumatoid-like erosion sometimes. And most important, key features are, you can clinically you may see this skin thickening, Raynaud's phenomenon, acroosteolysis, joint erosions, and what interstitial lung disease you may see normally? What pattern you will see? Kapil, are they they're typing the chat box? Anybody? No, suddenly not. Oh yeah, it's coming. What type? Yeah, NSIP. Excellent, excellent. NSIP pattern. Very good, very good. I'm able to see the chat box now. So there will be multi-system involvement. So that is about a scleroderma, the first spotter. So this is a case of multiple exhaustosis. So there are multiple exhaustosis. What you need to, what is Trevor's disease? Anybody? What is Trevor's disease? So Madelung deformity, a very well-known deformity, is most commonly seen with a multiple exhaustosis. Then you get this sessile broad-based exhaustosis. So you also get a narrow pedunculated exhaustosis. Multiple osteochondromasis is more dangerous than regular sessile osteochondromatosis, where the chances of malignancy is higher for multiple osteochondromas. Any named disease for multiple, what do you call them as? Diaphaseal aclasias. Very good. So the chances of diaphaseal aclasias making malignancy is 3% compared to a solitary exhaustosis, which is 0.3%. Okay, this is what you have to understand. And the key features are metaphysis of long bones and continuity of the exhaustosis with the underlying bone cortex. And you may get this pseudo Madelung deformity or Erlen-Meys deformity in cases of that. And Trevor's disease is nothing but dysplasia epiphysalis hemiphylica. In my 120 spotters, we do have a Trevor's disease. That's why I mentioned that early. And also we do have a Nora's lesion also in our cases in the coming spotters, which is again a bizarre proliferation of, especially in a wrist radiograph you get. And also you have to differentiate it from multiple enchondromatosis. In multiple enchondromatosis, the shape of the bone will get deformed, unlike a osteochondromatosis. Why? Because the growth plate growth will be affected by the enchondromas. That is the problem. So that so you in enchondromas, unlike the diaphaseal aclasias, there will be more deformities. So that is what you have to understand. This is called myositis ossificans progressiva. Nothing much to learn about this. Nothing much, like not much, because it's a sheath-like calcifications here. You should have observed these things. So dermatomyositis, if you have written, you can take those spotter. I would have given dermatomyositis. So calcifications in soft tissues ultimately, and you should not get carried away or give it as some bone tumors or something like that. So what I would like to tell is progressive heterotopic ossification. So unlike localized, it comes like a sheath-like ossifications. And differential diagnosis, all these things like juvenile myositis, soft tissue sarcomas, and everything else. But it's a spotter, nothing much to learn about it. It's Klippel field. You should have appreciated. Sorry for that. Immediately, I have not got given the 3D rendering. But here you should have been able to pick up this WASP waist sign. There is something called WASP waist sign. So the WASP body appears like this. Then suddenly it weighs down and it comes like this. Similarly, cervical vertebra, there will be WASP waist sign in case of Klippel field anomaly. So you will be able to identify that block vertebra. And also in this case, there was a clear associated Sprengel deformity also, if you're able to see that the scapula is high riding. So Klippel field is mostly associated with omohyoid vertebra or a Sprengel deformity. These things you can learn about it. So this is the WASP waist sign, which I was talking about. And there can be scoliosis, short neck, congenital fusion of two or more cervical vertebrae. You should always think about it. Look at the coronal CT. Then you look for those associated anomalies. In case of short neck, posterior hairline and limited range of neck motion is scoliosis, Sprengel deformity are associated. So you should always rule out from ankylosing spondylitis whether there is ossification of anterior longitudinal ligament or something like that. Okay, this is a straightforward case of. So what are the differential diagnoses at this point for this lesion? You can type down in the chat box. This is osteochondritis dissecans. I have given this. In a medial side, what else you can think about? Anybody? There is something called SONC. Okay. There is something called bone infarct. No, SONC or SIFIC. SONC is spontaneous. SIF or SONC, spontaneous osteonecrosis of knee. So what will happen in suddenly there will be infarcts, multiple repeated infarcts, and there will be collapse, and it will be a more larger lesion. SONC is a larger lesion. And again, SIFI is subchondral insufficient fracture. There will be a fracture line seen here with severe hyperemia. So this is secondary to osteopenia, osteoarthritis, more advanced osteoarthritis you see. So this is a cartilage lesion defect. Subsequently, there is a larger. T1 will estimate the exact size better. I think stir images will give the problem with edema. So stir is not really very reliable in these cases. Subchondral bone. So what I've said, osteochondral. You always have to look for the loose body in a knee MRI. In my early days, like with my now post MD 13-14 years experience, now we look for the loose bodies whenever you see that osteochondral defect. Before we used to report this osteochondral defect and just leave it off. You have to search for the joint effusion osteochondral defects in case of lesion. So this is a case of osteochondroma. There are so many osteochondromas because it's going to be a sure short spot for you people. Definitely somebody will pick up and get a spotter or maybe that. So it is an MRI. You can see this cauliflower-like involving the posterior elements. These are the buzzwords: posterior elements, cauliflower-like lesions, and cartilage cap. What is the normal thickness of cartilage cap? And after a certain level, you should think of malignancy. What is that level? Anybody? Greater than. Absolutely right. Absolutely right. Yeah. Fantastic. Fantastic. So this is a cartilage cap. You have to think bony outgrowth, metaphysis of long bones. Then there will be continuity of cortex with the medullary cavity. And so enhancement also will be there of the fibrovascular tissue or a cartilage cap. The key point is continuity of cortex. Cartilage cap best is seen on MRI. The thickness is 1.5 centimeters. Typically arises from the metaphysis of the long bones. So these are the things we have to think. So again, this keeps on coming, BPOP, and this is the subperiosteolymptoma. All these things are very rare. I think chondrosarcoma is one thing. What is the differentiating feature between chondrosarcoma or long bone tumor? How will you differentiate both? So there will be widening of the medullary cavity. When it is going for a low-grade chondrosarcoma, the lesion size, the lesion will be, benign one will be more together. When it is becoming more malignant transformation, the calcifications become more dispersed, and there will be more of a endosteal scalloping. The medullary cavity will definitely get widened. So these are the features. Endosteal scalloping, dispersed classification should always, in a long bone enchondroma, you should think of chondrosarcoma changes. So the question was not regarding osteochondroma, the question was regarding chondroma going into chondrosarcoma. Okay, this is a case of psoriatic. What is this sign? What you are seeing? What is this sign? Not really. This sign, especially this one. Very good. Trishia, yeah, Trishla. So this is the case, penicillin cup deformity. There will be what are in advanced cases only you will be able to say. In the early stages, you see this sausage type of disease. So there will be coexisting of erosions, asymmetric joint involvement, and so sometimes there will be some degree of asymmetric sacroiliitis. All these things are seen. Dactylitis can be seen as a sausage disease, detectable very well on MRI. There will be involvement of nail involvement in distal phalanx, nail involvement and distal phalangeal involvement. So how will you differentiate from other causes? There will be symmetrical involvement in rheumatoid arthritis. There will be juxta-articular osteopenioma. In psoriatic arthritis, there will be maintained bone density. Bone density is one thing when you should always comment in cases of arthritis. Okay. normally. Then if it is rat bite, somebody answered, it's more of gout lesions. You get a rat bite, not the psoriatic, you get this penicillin cup type of erosive osteoarthritis. So this was a case of enchondroma. So this is what I was talking about. So I would like to ask, what are the things will you describe a bone tumor? What all will you describe? Somebody type in the chat box. What all will you describe? Site, very good, Abhishek. Zone of transition, yeah. Matrix. Aggressiveness, yeah. Yeah, very good. So yeah, the Krishna, I was expecting the stamps. Absolutely right. I was expecting the stamps. You have to tell the age, you have to aggressive, not only aggressiveness, age also is very important. Multiplicity is also important. So I can add some M's and A's for it. For example, site is important. Then transition zone. In this case, it is wide or narrow zone of transition? Is it wide zone or narrow zone of transition? Narrow zone, very good, excellent. There is a clear margin and we are able to differentiate normal bone from abnormal bone. So this is a narrow zone of transition and there is a cortical breach, you are able to see. So stamps mean site, once again for people who don't know the mnemonic. T is for transition zone, A for age and aggressiveness, both. M for matrix. In this case, what matrix is in? Matrix and multiplicity. I'll add multiplicity for that. Age and multiplicity. P for periosteal reaction and S for soft tissue. So I always tell, so 2 A's and 2 M's actually. I added age and multiplicity. Aggressiveness, matrix, multiplicity. So stamps, 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 stamps. Follow the stamps. If I would give you one take home point today, it is for stamps. You see, even in a busy day, you'll quickly report as a GCT or something like that. Sit back and address and describe according to stamps those cases. So you'll get more better more differential diagnosis. So this is a case of enchondroma where there is stipulated popcorn or arc like of calcification, narrow zone of transition, cortical breach, tubular bone. What is the closest differential diagnosis you would like to give for this case before closing it? Closest differential. Sorry. Sorry. Hello. Yeah. 10 minutes. Sorry for that. Spina ventosa was the right answer, Abhishek. So dactylitis, tubercular dactylitis is the one which is most important. You have to always think when in a short tubular bones. 3 days back also we have got a case. So ultimately, I've discussed everything: continuity of cortex, medullary thing, and lesions are generally less than 5 centimeters, most common in hands and feet. So low-grade chondrosarcoma, I already told the differential, how to differentiate it. Then bone infarct, bony island. Chondroblastoma is more of epiphyseal location. Bone island, again, it won't have that lytic component. Bone infarct in long bones is definitely a differential diagnosis. In long bones, bone infarct is a differential diagnosis. Okay, this was actually nowadays examiners are so fancy about the syndromes. Definitely, what is this deformity? What you see? What is this? What is this you're getting? Shepherd Crook deformity. Patient also has a what does a patient have? Patient has So this is a McCune precocious puberty will be there, multiple fibrous dysplasias. Then you'll get these cephalate spots. All these things are features of McCune Albright syndrome. And ground glass opacification is regarding, I'll give a clue regarding this fibrous dysplasia. Whenever you are seeing a lesion, which you think it's so benign, but it's so abnormal. So if you have this feeling, you always think about polyostotic fibrous dysplasia. And these are the things you get in a polyostotic fibrous dysplasia. Okay, this was a case of Paget's. This is relatively tough one because the thickening of iliopectineal line and the pubic bone expansion, the mixed sclerotic lytic. And whenever I can tell you, seeing so many students, normally what will happen is when we give multiple images, no, you try to concentrate on everything at once. Approach even then, if you have been given 20 seconds, spend some time on one image at a time and subsequently go to another image so that like you'll have that approach. So this was a case of Paget's disease, and the typical signs in Paget's disease are, I'll repeat some of the most important spotters so that like there is another Paget's coming up. So then we can discuss in detail about Paget's. Lytic and sclerotic phases were seen in this case, and there was bone expansion in ischium and pubis, you will have seen, and axial skeleton is very much involved. Sometimes rarely or like relatively less commonly long bones are involved. There will be elevated serum alkaline phosphatase level, and you should have not confused it with a metastatic bone disease or so what is the differential diagnosis most of you have written. If you would have got it right, I would have been rather very happy, but relatively I felt that was okay. We'll go to the second set. I'll be a little faster, I was getting used to that pace. USG image. Two cases. Same companion image, knee ultrasound, 5 seconds. Okay, there was one repetition. You can see the first case was multiple myeloma. We discussed brown tumor, Marcus syndrome, osteoid osteoma bar osteoid, osteoblastoma, osteopyklosis, Mafuki syndrome, then melanostosis, Osgood shatter, cleidocranial dysplasia, and diaphyseal eclasia. Let us go directly. So these are multiple punched out lesions. In skull, you're seeing multiple punched out lesions. Also, if you carefully see, there was some severe osteopenia and also vertebra plana was seen. So this you could have definitely given a differential diagnosis of multiple myeloma. If not, the other differential, you could have called it as hyperparathyroidism. So it's very close differential diagnosis. I'll tell you how to differentiate. So you get this fish vertebra, moth-eaten appearance. So this was a case of multiple myeloma. But how will you differentiate it from metastasis? Come back down here. This is one of the most important. Myelitic lesions commonly involve posterior mandible in case of multiple myeloma. Rarely involves mandible. So metastasis, even though it is diffuse, it doesn't really involve the mandible that much. And also vertebra plana is common in advanced stages. Normally, collapse is relatively rare. It's not like we can definitely differentiate. So these two are very close. That's why you advise a PET CT or look for the gamma globulin levels and everything. And most of the times you get this sclerotic from prostate and lytic from lung, and these are the differential features. So these were larger lesions. And also I have given the clue of this hyperparathyroid adenoma in the neck region. And also you can see these looser zones are fractures, insufficiency fractures. And here there's almost, they're going for advanced scapholunate collapse. And there is some degree of acroastolysis and laminar dura ossification or resorption you are able to see. And also if you carefully see, this is a what pot skull? Waiting for your answer. What pot skull? Pepper pot. So everything in one. This can be a long case for you, and everything I have covered. And one of you out of you 37 who have enrolled or whoever are there, one will definitely get a long case or short case. Just don't forget to text me regarding that your hyperparathyroidism. So this is a hyperparathyroidism. You are able to see. Next case is So this is a case of Marquez disease. So what you were able to see, you was able to see the central beaking. Very good, excellent. So bullet-shaped hands, and so these are the major features. And you have to differentiate. One will have Hurler will have thickened calvarium. Marquez will have J-shaped cella, and this wine glass appearance is more commonly seen in Marquez syndrome. And metaphyseal flaring at genu valgum is seen here. There will be diaphyseal widening in Hurler syndrome. So this you have to be aware of these things, and you should be able to answer when somebody asks specific questions. And this is a straightforward question. I don't want to spend much, but one of the most important. What are the differentials you would like to think whenever you're given a case of osteoid osteoma? What are the differentials you'll think? No, not really, not Brody's. You have to think about stress fracture. Stress fracture, and this case, yeah, osteoblastoma. It's not a differential diagnosis. This is a osteoblastoma, bigger lesion, nidus greater than 1.5 centimeter. What I'm trying to tell you, think about stress fracture, and also Brody's, yeah, not Brody's actually. We can call it as early osteomyelitis or something like that. Periosteal thickening alone, rather than clear defined Brody's. Okay, so size and nidus CT is the best modality. MRI will show the edema and a greater trochanter, long bones, severe pain, aspirin resorption, all these things are common buzzwords they'll ask. You should be able to answer. And also nuclear scan, you get this donut sign. Okay, this is straightforward. This is a case of osteopoiclosis. Nothing much to add. This is more of a dysplastic bone. You get this typical multiple dots and osteopathic striata and osteopoiclosis. You have to see spot, nothing to discuss about that. Maffucci syndrome, multiple enchondromas associated with hemangiomas. In fact, this is a borrowed slide from internet, you all know. So this is a Maffucci syndrome. And also you may get this when they may keep a spotter with angiogram where there will be too much of hemangiomas taking up slow flow blood. That is how you diagnose. This is a case of malarastosis along dermatobal distribution. You get this ossification and periosteal reaction. Flowing is the word, very important. Your candle wax dripping is the common word you have to use. So this is a case of malarastosis. Then this is again Osgood-Schlatter's disease, tibial tuberosity fragmentation and edema. So this is a Osgood-Schlatter's disease, tendinosis. Then you get this. This is a classical case of cleidocranial dysplasia. Look at the clavicles here. There are Vermean bones. There is too much of increased density. And how will you differentiate it from pycnodysostiosis? Oh, sorry for this wrong. Pycnodysostiosis, you get this acroosteolysis, unlike the cleidocranial dysplasia. Here, clavicles will be absent. You get this. These are called Vermean bones. Also, you'll be. So in fact, Trishla, we do have a jumper's knee also spotter, and you can wait until that, and you will get the answer. Jumper's knee and Osgood-Schlatter's. How will you differentiate? Yeah. So this is a repetition. I will like just skip and we'll move on. So pseudomedlung. This is the case of again diaphyseal achalacias. We have discussed in detail regarding that. Okay. So diaphyseal achalacias. So you get this called coat hanger exostosis. I would like to. There's a very small exostosis you get in diaphyseal achalacias, unlike this lytic lesion with rings and arcs of classification. And this has a higher risk of chondrosarcoma. These are the two things which again and again somebody will ask. Travers disease is epiphyseal. Okay. Next round we are going. What is this? Hope you are all writing the answers. Without writing, you will not get the memory. To try to attempt, and these are the last two cases. Yeah. Let me go straight away. What we have discussed is first one is Sever's disease, glomus tumor, Eagle syndrome, sacrococcygeal chordoma, bilateral lateral end of clavicle erosion, vertebra parana, deep sulcal sign, acromegaly with spade of tufts, amniotic band syndrome, and arthrogryposis multiplexa congenita. So this is so you all know this is straightforward case where there will be calcaneal apophysis which will be involved because of repetitive trauma. You should not differentiate. You should differentiate it from calcaneal osteomyelitis, and subsequently, if the patient is he may develop a calcaneal osteomyelitis. So this is a Sever's disease, and this is a young child you should have picked up. These are the fragmentation in the calcaneal apophysis is the buzzword, and subsequently Achilles tendon insertion may be involved, and ultrasound is sometimes useful. You can tell how much any collections formed or not, and this is about calcaneal apophysitis. So there is a tip whenever somebody is showing an enhancing or a star hyperintense lesion in the tip of the finger, you always think about glomus. Until now, I would have diagnosed more than 15 or 20 glomus tumors. All are operated and become symptom free. Very common location. Only MRI can pick up those things, or maybe they have to do a DSA. So small lesions in a tip of the finger, we always think about glomus tumors. Okay, so this is it's so big. It is shooting, and in fact, I've made multiple videos in my radiology case videos channel. So this is a elongated styloid process greater than 2.5 centimeters. We should always think about Eagle syndrome. Specifically, they'll present with pain in the tonsillar fossa. We should always look for that styalgia. Incidentally, also, we have picked up a few cases where, of course, clinical radiological correlation is very important. Okay, this is very one spotter. Again, it can be a short case. One of you can get it as a short case. So incidentally, there is also Tarlos cyst in this case. What I would like to emphasize is this typical sacrococcygeal chordoma, where there is bright on T2. Bright on T2 is the buzzword you should answer in the exams. There is no doubt about it. And also, this is highly recurrent tumor. I had a patient who has undergone more than 7 or 8 scans in a period of 2 years in my scan center. Patient was in 3 times he was given radiotherapy and everything, but it was growing. Ultimately, because of the unusual location, he had so many complications and he succumbed. So that way, it is a recurrent tumor. And the other typical location is, I would like to have an answer in chat box. Where is another typical location? Axial spine. Typical location. Very good. Very good. Please, everybody. Sumita, good, excellent. Abhishek, Trishla, participating very well. Good. Thank you. So this is it. Clivus is the lobulated appearance, bright on T2, cartilage tumors, bright on T2. Chondrosarcoma is also but very common differential is chondrosarcoma. Then you have these giant cell tumors. All these things are long bone, but it's very classical. You can't give a differential diagnosis of a giant cell tumor or metastatic disease for a T2 so bright tumor in our case. Okay, pseudopodia-like appearance that somebody may ask you. And again, lower FDG compared to the other sacral malignancies. Okay, this is one important thing, lateral end of clavicles osteolysis. You're able to appreciate. So very common, they'll chest X-ray you should have picked up. It's a challenging again. Bilateral erosion. What are the differential diagnosis? Hyperparathyroidism, rheumatoid arthritis. Very good. Somebody is answered. So atraumatic distal acroasteolysis, and also scleroderma, pycnodysostosis, as I was telling. You can have this picture. Vertebra plana, numerous. In fact, Sachendra was very generous to give a long mnemonics for that. Multiple lesions are there. So these are the list of differential diagnoses. Whenever you see this vertebra plana, you have to tell, based on age, you have to tell Langerhans histiocytosis, lymphoma, trauma, myeloma, rarely hemangioma, aggressive. So all these things are a differential diagnosis. Severe uniform loss, greater than 70% reduction. You can't call 50% reduction as a vertebra plana. And again, kyphosis angle is greater than 15 degrees. These are the things we have to be very aware of in vertebra plana. So this is a typical deep sulcus sign, very commonly seen with ACL ruptures. Whenever there is ACL rupture, nothing much to add. I don't want to spend much time on it. So lateral femoral notch sign are also called deep sulcus sign. It's a pivot shift injury hallmark. I always write in the reporting pivot shift type of marrow edema with the deep sulcus sign seen, consistent with lateral femoral condyle notch sign. Acromegaly, you get this spade of tuft sign. So this is basically in acromegaly, you get this skull calvarial thickening. Spine, you get this vertebral fractures. Hands and feet, you get this heel pad thickness increased, and you get this spade phalanx sign. So it looks like a spade of. So you have to be able to diagnose that. So amniotic band, nothing much. So bands will come, and so no differential diagnosis. It's a spotter. You have to identify, and sometimes the limbs get amputated. That much I can tell you, and also differentiated with limb body wall complex. So this is this is what multiple contractures will be there, consistent. Tougher ones, how much ever you are brilliant, 10% of the spotters you can expect out of the world. 10% you have to do some degree of mistakes in the tension are okay. Most of you should score above 80% to be, or like maybe you have to fit in between 70 to 80%. So your effort should be towards that. Okay. So this is I'll skip over it more fetal medicine oriented lecture. So we'll go to the next set of the spotters. Yeah, third, write down, please. I'll give a clue for this case. Mother had some intrauterine infection. This I'll give another clue. Parents are hiding something. Okay, the first one is congenital syphilis. I'll teach you what is it, and this is metaphyseal corner injury. Somebody has written that it is a non-accidental trauma or a child abuse. Then that is a Paget's disease with cotton wool disease, dequerens tenosynovitis, dish, Travers disease, which I told that I'll get it again, and extramedullary hemopoiesis was classical, erosive osteoarthritis, seagull appearance, green stick, and intracortical hemangioma. So this is the uniform periosteal reaction. You should have picked this, and I'll discuss the theory about it. Congenital syphilis not seen very it's almost like you get this widespread periosteal reaction, we should appreciate. And then this periosteatis, you get this people will have dental abnormalities and calcifications where I gave a clue that there is intrauterine infection. So congenital cytomegalovirus, child abuse are the other differential diagnosis for congenital syphilis. So periosteatis, diaphysis, metaphysis is the clue you have to learn. So this is metaphyseal corner injury, most commonly seen with non-accidental injury. So occurs in children greater than 2 years. Distal femur and proximal tibia are involved most commonly. So, nine. Okay. Again, some more injuries we can expect in case of non-accidental trauma. You can type what all you can see. Yeah, rib you can definitely see, and also skull fractures you can expect. So posterior rib fractures, absolutely right, Abhishek, right. So cotton wool, you get this. So this is so bright. Anybody who's Tom O'Shanter skull? What is that? Tam O'Shanter skull. You read about it. Anybody knows? Okay, that's okay. Dental. Changes. So this is what is the. These. Sorry for that. Okay, this is a case of decurrence tenosynovitis, where you can see that both the tendons are affected. In what are the both tendons? What are the both tendons? Very good. Abductor pollicis longus and EPB, ECRB. Yeah, very good. So both the tendons, there can be severe tenosynovitis. This is the first compartment tendons. They can have this typical. You can also see the increased vascularity and Doppler imaging, thickening edema in the first dorsal compartment. So you should differentiate from intersection syndrome, which is for the other extensor tendons, proximal intersection. Second, subsequently there will be distal intersection syndrome. Those things are there. Decurrence partially stenosing, typically at the level of radial styloid. So this is very hallmark, more than 4 vertebra. Very commonly, somebody will be writing for 2 vertebra. So at least 4 contiguous vertebral bodies will be there. Preservation of disc height is very important. Osteoporosis is not the feature of dish. These are the important things. You should know when not to call dish. All these things will help you. So preservation. Then you should always look at the association with OPLL in 50% of the cases. So differential diagnosis, ankylosing spondylitis. So very good, you have done well. So this was what she was asking. This is the Travers disease, dysplasia epiphyseal hemimelica, and you get this typical asymmetric epiphyseal enlargement because of the involvement. There is male predilection. This is osteocartilaginous growth of epiphysis. Okay. So this is typical. I most of very fascinating case. You get to see, and this is what is the. This is the erosive osteoarthritis. So the seagull type of erosions are seen, joint space narrowing, gulving erosions in erosive osteoarthritis. If you give that, typically you see that gulving, you don't give any other differential diagnosis. In psoriasis, we have seen the penicillin cup deformity. So this is completely different. Gulving is like almost you get this M-shaped erosion, you see. So you have to differentiate. This is green stick fracture. Both the cortex are really involved. So this is a typical green stick fracture. And these are intracortical hemangiomas. I do have some videos on hemangiomas in my case videos. I'll share the link. You can go through and read about them. So next set will go. So what we have to understand is you get this typical lack of aggressive features or periosteal reaction, cortical based lesion. You should always think about it. Okay. Next set will answer. Sometimes it always happens. Answers will be there on the films. If I am right, this is one of the toughest round, I believe, because it was more of conventional. It was more of dirty looking X-rays, typical hardcore old age examiner style of. So luckily, off late when I'm going as an examiner, you're not getting such tougher ones. That is good news. That's why I ran through that. But you have to know these things. There is no other go. The first one, as Trishla was asking, jumpers knee. I'll just show you. This is more of patellar tendinopathy at the patellar insertion, not the distal tibial tuberosity insertion. That is how you differentiate. I'll show the image also. Subsequently, there was a Kohler's disease, Kummel's disease, Lachner skull, leprosy, and liposclerosing myxofibrous. Once you see, you will not get it wrong. You have to see few cases of this. Then you get this lunar dislocation, mallet finger. And so this is one of the, out of my 120 spotters, this is one of the toughest set, I believe. So medullary bone infarcts are the. So this is where you get this jumper's knee. And also we have published a paper where patient developed a large intrapatellar tendon ganglion cyst following a jumper's knee. So very common. There will be fluid tracking and there will be formation of cysts in the ganglion cyst. So characteristic location and proximal 1/3. So differential affects the tibial tuberosity. And Sinding-Larsen-Johnson syndrome in inferior pole of patella affects the younger patients. So jumper's knee and these two are synonymous. You should never get confused with these two. So jumpers and Sinding-Larsen-Johnson are common. And so Kohler's is a collapse of the, you get this flattening fragmentation of the navicular bone. So this is the Kohler's disease. What is Freiberg's disease? Anybody? Freiberg. Freiberg. No. Not fifth. Third or fourth metatarsal head is the Freiberg's disease. That is what you have to. Yeah, very good. Soumya is right. So that is the Freiberg's disease. This is Kummal, air within vertebra, very commonly seen in CT. Collapse with air is Kummal's disease. This is Lachner shell, very badly exposed X-ray. It's okay. Sometimes you get into such things. You should be ready for that. Nothing much to discuss about it. So liquid candlestick is very well seen. Arrow was also pointed. And so that is how you have to identify the leprosy, thickened nerves, those things they may ask. And asymmetric joint involvement, penicillin cup, psoriatic arthritis is very close DD, and gouty arthritis is very close DD for leprosy. And this is a case you have to just see on-to-many approach, nothing much to add, metaphyseal lesion, liposclerosing, and MRI can help. T1 weighted followed by T1 FS will definitely help you giving this myxofibrous tumor. Okay. Histologically, malignant transformation can occur, strong proximal femur, intertrochanteric region. So hallmark. Ground glass you see in fibrous dysplasia. Intraosseous lipoma, you get this typical milligram staging and everything. So that can be the closest differential for this. So this definitely there was a dislocation, lunate dislocation here. and also suspicious for fracture. Here there is a suspicion for fracture. So lunate dislocation is there. So you have to differentiate between lunate and perilunate dislocations. Spilling of cup is the hallmark. When lunate is anteriorly dislocated, you have to give it as spilled cup or teacup or something like that. It's called lunate dislocation. So disruption of Gilula's arc will be seen, and spilled teacup sign is a common diagnosis. There will be triangular piece of pie sign in AP view. So you have to get oriented, read about lunate, perilunate. Somebody, especially FRCR, it's a hot favorite topic. You read about them. Angles also they will discuss. So these typical mallet fracture, nothing much to discuss about it. Your inability to actively extend the DIP, patient will come with typical history. There will be a fracture, often caused by forced flexion of DIP. There can be tendon aperture and avulsion. So X-ray itself is helpful. Sometimes MR can give you better delineation. So that's a mallet. Pellegrina MCL avulsion fracture. Commonest is Pellegrina stida, differential diagnosis, which is MCL attachment calcification. That's called Pellegrina stida. So in this case, it's more of an avulsion injury. All avulsion injuries, write your report as grade 3 tear of the ligament. Subsequently, you can write is it tendon is healthy or not, or ligament is healthy or not, you can mention. Because they'll fix it with a avulsion with a button. In fact, if the tendon is or ligament is also torn, they have to first stitch that ligament, then they have to fix it. So report, it is whatever it is, it's grade 3 tear, but you have to mention about tendon health also subsequently. So these are multiple medullary bone infarcts. The differential diagnosis for medullary bone infarct is long bones, especially post COVID. We have seen so many medullary infarcts because of steroids. The long bones was showing so many. But the closest differential diagnosis for medullary infarct is bony island and enchondroma. Both, if you have to, both will show this sclerotic long. But medullary infarcts are more bigger lesions, can involve multiple bones. Unlike enchondroma, they won't show much of calcifications. So, but anybody asks you what are the X-ray differentials, enchondroma, bony island are the closest differential diagnosis. Okay. Again, one more, the in between sets, I have kept it as tougher ones. Yeah. Nothing much, you can write whatever you feel like. If somebody has written malarastosis, I'll give it to them, but bones are normal. Clue. Okay, the first one was the toughest for me also, to be honest. Metaphyseal chondrodysplasia. Then you get this multiple epiphyseal dysplasias because there are so many destructions of epiphyses. Then we had this Jaffe-Campanasi syndrome, and this myositis ossificans, one of the toughest myositis. And we have this Nora's lesion, also called bizarre parasteal osteochondromatous proliferation, very common in hands. Then this disc classification, ochronosis. Then we had the skull intraosseous hemangioma. We had this osteofibrous dysplasia in the distal tibia, then osteophyta humerus, then osteopetrosis. So this was just, you have to commonest for rickets. You can think about mitochondrodysplasia. You have to have this antimony approach, nothing much to add about it. Then we have this metaphyseal chondrodysplasia, which is common. It looks like rickets, but epiphysis is involved very much. So you have to think about these things. What we get is moderate stature, bowed legs, coxa vara, characteristic metaphyseal changes in metaphyseal chondrodysplasia. Okay, so this is again a case of multiple epiphyseal dysplasia. Here you get this destruction. Here also you get this epiphyseal destruction. Symmetric involvement of multiple epiphyses you get in multiple epiphyseal dysplasias. Don't worry, this is all so classical, old school teaching. That's why relatively nowadays not many people are getting such cases. If you don't know, it's okay. You can brush up, have an idea about them, have an antimony approach. But the middle two rows of spotters, I wantedly bought it because it's a old school of suddenly if somebody senior comes up with such cases, it will be really challenging. You should not miss them. So these things are relatively multiple knobs. You get this Jaffe-Campanasi syndrome. I was just pointing an arrow while you were writing. This is Jaffe-Campanasi. And they may definitely ask about capillate spots will also be seen like McCune-Albright. You have to think about giant cell granulomas in the jaw also. Okay. Multiple non-ossifying fibromas in a case of Jaffe-Campanasi syndrome. So this was a case of myositis ossificans. I said bones were normal to give a clue. Tougher one, I agree. So this is a case of myositis ossificans with Ackermann zonal phenomena. So characteristic zonal phenomenon, large muscles, especially thigh and arm, history of trauma, evolving imaging appearance over a period of time. So these are the concentric zones. You can go through your read. String phenomenon is also seen on CT. So this is a Nora's lesion. So you can definitely, somebody, MSK radiologist comes, they'll definitely ask. So these are called BPOP, bizarre parasteal osteochondromatous proliferation, and also called Nora's lesions. Yeah. You should differentiate it with the osteochondroma, where you'll see a continuity with medullary canal. In this case, you won't see a continuity with medullary canal. So this was a classical ochronosis where there was disc calcification and also some degree of disc disease. And this is the thing. So bluish black gray pigmentation, changes in the spine, arthropathy, ocular manifestations. Then differential diagnosis, ankylosing spondylitis. That is Anderson lesion or discrete Anderson lesions of angspond will look like ochronosis. So intraosseous hemangioma, hallmark, nothing much to discuss about it. So fibrous dysplasia, I would like to spend 1 minute on it, because any tibial lesion, commonest dysplasia in children, you have to think about osseous fibrous dysplasia and adamantinoma in adults. So both things are tibial diaphyseal lesions. Adamantinoma and osteofibrous dysplasia can be easily given as a spotter in exams. You should be aware of osteofibrous dysplasia or adamantinoma. Ground glass opacification, especially adolescents, osteofibrous dysplasia is common. Osteophyta striata, so you should not confuse it with some film artifact. It's a older school of teaching. You should be able to diagnose that. That's all. Osteopetrosis, fractures, and dense sclerotic bone, sometimes bone within bone vertebral appearance. All these things will be seen in osteopetrosis. So next set of questions. So we had this definite synovial osteochondromatosis. Sorry, this classical osteopoikilosis, then paraosteal osteosarcoma we discussed. PCL avulsion fracture, straightforward. This was very easy spot around. We got this Perthes lesion. Then we had this posterior hip dislocation, posterior shoulder dislocation. We had this stellary stalk appearance and proximal radioulnar stenosis. So nothing much to discuss. Straightforward osteopoikilosis. Second time I'm getting this spotter because it's more important. So this is a autosomal dominance inheritance, somebody may ask, and differentiated from osteoblastic metastasis. Okay. Then this paraosteal osteosarcoma, typical location and very dense osteoid matrix. Your not many differentials you can think about it. So osteochondroma, it won't be so dense, and myositis ossificans, definitely you won't get dense mineral matrix, or you won't see any communication with the periosteum. So these two are the closest differential. Slow growing typically affects the young adults. Then metaphyseal regions are affected, painless for a lot of years, better prognosis compared to conventional osteosarcoma. These are the points you have to write about paraosteal osteosarcoma. Again, different. They may ask about what are the types: periosteal, paraosteal, then conventional. Then you can tell about telangiectatic osteosarcoma. Then they may ask about chest metastasis. In case of osteosarcoma, you should be able to tell about chest metastasis. So this is the osteosarcoma. So typical synovial osteochondromatosis, where we get calcifications in intra-articular. There will be some degree of bone erosions in 20 to 50% of the cases. You get chondrite mineralization, and primary, you will get this unknown benign neoplasm, and younger patients, primary will be seen. In older patients, secondary, it's more of chronic joint pathology, synovial metaplasia, and underlying arthritis will be seen in case of. And PVNS is one thing which is very important, where you get these calcifications, and also typical villous appearance will be seen, and also you get this gradient. There will be a lot of blooming in PVNS. This you can help differentiating other conditions from synovial osteochondromatosis. You won't get this calcific loose bodies in PVNS. So classical PCL avulsion, always measure the avulsed fragment before giving the report, and always mention the displacement, how much is displaced, and mostly how is the ligament status. These 3 points we'd like to write in your report: size, distance, and also how is it torn. Okay. So this is one MCL avulsion we have seen. This is calcification avulsion called Pellegrina's lesion. Okay, nothing much. You can just skip this. Yeah, Bunkart lesion. Always nowadays Bunkart lesion occurs here. If the Bunkart lesion along with the periosteum is avulsed, then it is called Perthes lesion. Okay, periosteum is intact without complete through and through cut. If there is complete through and through cut, you should have labeled it as Bunkart, but only it is lifted. The periosteum is lifted without a clear separation. So that is why it's a Perthes lesion. They may ask you about Glad lesion. They may ask you about Bennett lesion. They may ask about other types, Alpsa, Polpsa. So you read about it. Radiographics has given a wonderful graphic about it. You can go and read about it. Intact periosteum. So I said no, Glad, Alpsa, sublevel recess, all these things are. Alpsa, there will be elevated, will go tuck into the periosteum in Alpsa lesion. Glad lesion, there will be associated cartilage injury. Glenoid cartilage will be damaged in Glad lesion. Okay, this was a posterior hip dislocation. There was following a dashboard injury. High energy trauma, vascular incident. This is a posterior shoulder dislocation, light bulb side. In fact, the graphic itself was made and showing to you. So most commonly, electric shock or high energy trauma will give you typical. This is a classical one. Nowadays, people are so fascinated, and definitely one of you may get this quarter. So celery stalk, high signal and T2. There is a role of intervention radiologist. They can give PRP injection, or maybe they can suck up the fluid. So the patient will become symptom free. This is a relatively younger patient, almost I think 40 or 35-year-old. So we can do something about it. Okay, this is a proximal radial nerve stenosis. Antimony, you see it, you know it, you write it. That's all. It's as simple as that. Okay, this is a next set of answer. Last few will be really faster because we are running short of time. Repetition. Young boy. History is young boy. Okay. So the first one was reverse Sigand fracture. The first one was reverse Sigand fracture. Sigand's fracture is associated with which ligament injury? In how much percentage? I just want to check people are awake or not. How much percentage? Okay, not 75%. 90% above. 90% above Segond's fracture is associated with ACL injury. So this is what we have seen is Segond's fracture is on which side? Lateral or medial? Very good. So this is reverse. This is on medial side. Okay, agreed. So rickets we have discussed, and spade phalanx is a repetition. Schurman's disease. We have this Smitar sacrum. We have this spondylar dysplasia tarda. These were the toughest in the round, and this is commoner, suprascondylar spur, talocalcaneal collision. You may get hair on and AVN of these ones. So this is the reverse secant, not on lateral side by fracture, which is very important because injury of the medial collateral ligament. So that is what you have to. Second is lateral tibial plateau with ACL tears. Okay. And then you can also see the arcuate sign, or you get this fibular head fracture with reverse secant. So rickets, you get this metaphyseal flaring, and classical one, suddenly they may get it in the exams. I don't write it off. Rickets can be there. Still, there is malnutrition in India. Suddenly, somebody will get an rickets X-ray. Don't get fooled, and don't write some fancy diagnosis like epiphyseal dysplasia or something like that. This is the classical rickets, that flaring and all we are able to see. Okay. This is we skip, and this we have discussed. Spade phalanx already. Schurman's disease is multiple small nodes, exaggerated kyphosis, young pain, and kyphosis in young fellow. Always think about more than 5 vertebra anterior, increase 40 degrees. You have to think about Schurman's disease. Okay. And this is a rare case of Smittar sacrum. See it, learn it. Nothing much to discuss. I'll just keep it off. And this is again a challenging case where vertebra should be flat. Whenever you see this vertebral bump like this, you always think about this spondyloepiphyseal dysplasia tarda. Agreed? So whenever you see this bump, you can think about it is again shorter average height will be there, larger joints will be there, progressive arthropathy. So this is one of my favorite, in fact. So I have 2 or 3 cases. I'll keep on showing them. So this is a spondyloepiphyseal dysplasia. This is supracondylar spur. Unlike the osteochondroma, which goes away from the joint, the this is calcification of Struther's ligament, and you get this spur, and we should not label it as osteochondroma. That is the thing. 5 centimeters proximal to medial epicondyle. Okay, so these are the features. Supracondylar spur. So this is again a case of the C sign overlap, talocalcaneal collision, talocalcaneal collision. C sign. Okay, you get this. You are able to appreciate, no? Okay. Anteater sign you get in talonavicular collision. Tarsal collision. 45% of the case, commonest calcaneolavicular collision is the differential diagnosis. Anteater sign will be seen. Yeah. Heron seen in case of thalassemia or sickle cell anemia. Hemolytic anemias, differential diagnosis, all these things again can show hair on end appearance. This is snow cap appearance in a avian of humerus. So snow cap appearance, avian humerus. Yeah. Okay. This is, I think, repetition. Vertebra plana. I'll just keep it. Yeah. Okay, I said no, repetition of vertebra plana. Important ones I said it will be. Again, the other one, the hand X-ray was showing dermatomyositis. And Jacquard's arthropathy, I'll just show you and teach you about it. Then lead poisoning, that metaphyseal band. Then arcuate avulsion fracture we have discussed. Glenoid dysplasia, really tough one. And acromial, CT would have been easier for you, but X-ray was showing arrow. I think seeing the arrow, you should have been picking up. Chondromyxoid fibroma, it will haunt you and throughout your life. You'll keep on giving differential of chondromyxoid fibroma. So be careful. And cortical desmoid and also desmoplastic fibroma you've seen. Let us discuss. So vertebra plana we have discussed extensively. I'll skip this. Then this is dermatomyositis. What are the differential diagnoses? So characteristic skin changes, muscle involvement, systemic, all these things will be seen. Differential diagnoses are polymyositis, does not SLE, and lichen planus, all these things are differential diagnosis. And the crushed syndrome, calcinosis, tumoral calcinosis is one thing, but it won't be so symmetrical, so benign, involving so many fingers and all. That is how you differentiate dermatomyositis. Give a differential of tumoral calcinosis, always not an issue. So this is a Jacquard's arthropathy, ulnar subluxation. Typically, you see this hook type of erosions in case of Jacquard's arthropathy. There will be juxta-articular osteopenia and also there will be chondrocalcinosis. So reversible joint ulnar deviation of second to fifth fingers associated with SLE and other rheumatoid conditions. So metaphyseal bands seen in lead poisoning. What we are very much bothered are differential diagnosis. You have to look at other differential diagnosis, anemia, memory disorders, iron deficiency, sickle cell. So many things can cause a metaphyseal bands. Arcuate avulsion fracture of the tibia. You see the fracture of the tibia. This is arcuate avulsion fracture. LCL injury will be common. LCL injury. Where does the iliotibial band attach? Iliotibial band. Where does it attach? No, Sumita, no. Not fibular head, not fibular head. Gerdy's tubercle, anterolateral aspect of the tibia. So it's also called Gerdy's tubercle. So somebody may ask you that you should be aware. Biceps femoris tendon attaches to that attaches to LCA. Okay, now. So this was a case of glenoid dysplasia. Somebody should have identified this. The glenoid should have been round and beautiful. That is not seen. I think this is relatively easier one. So glenoid dysplasia, more prone for dislocations. That way, that is very important. Glenoid dysplasia. This is a case of os acromial. See the acromion. So the terminal fusion is not there. And it fuses around 20-25 years. If it's persistent after, you should really, it contributes to degeneration and impingement of the shoulder. Okay. 75% of the cases it is seen. So this is chondromyxoid fibroma, metaphyseal lesion. What is one hallmark I'll see is multiple septa will be persistent and it will be like a excavating cave. So if you see such an appearance in either fused or unfused epiphysis, always think about chondromyxoid fibroma. Always it should be in differential, second or third differential. It can't be your primary diagnosis based on my experience, I'm telling. You have to give your osteosarcomas, you have to give your GCTs as a primary diagnosis, then only you should diagnose it. A geographic, classical example for a geographic description, it's a more of a benign lesion, no? You get this sclerotic rim. So third decade of life, it is seen very well. It's more male preponderance and asymptomatic. Okay, this is a case of cortical desmoid, hyperintense lesion. This, in fact, when I was an examiner recently to Vellore, CMC Vellore, one of the examiner bought this cortical desmoid. He was talking everything except he has not mentioned a cartilage, a hyperintense thing as a cartilage tumor in MRI. So whenever it is very hyperintense cortical lesion, So cortical lesions, there's different set of differential diagnosis you should always be aware of. So rest and all you will crack, ABC, GCT, osteochondroma, enchondroma, all these things by now, I think at your fingertips, you will be able to diagnose. But if somebody gets a cortical based lesion or a chondroblastoma, or so those things you are finding little difficult. And especially with, I've seen people having difficulty with conventional radiographs. One good news is that the typical old school examination is not there anymore. So you get this, but this cortical desmoid, cortical periosteal chordoma, all these things are very common. They may ask about differential diagnosis. Okay, more prevalent. So take home is learn about the cortical tumors. So desmoplastic fibroma, very challenging. So I don't expect you to give that diagnosis whenever put a short case. But if you give a good differential diagnosis, like maybe chondromyxoid fibroma or something like that, I'll give it to you. So how much ever intelligent you are, 1 or 2 cases, you get such cases. Yeah. So next set will run very fast. We're running out of time. Liver and spleen enlarged is the take home for an MSK spotter. You can type it. Let's be interactive. Like you can start typing quickly. What is the deformity name? Very good. Repetition. Come on. Quick. Okay, we have given the answer also here. Huh? Tough one again. Some old man's tumor. Old man's lesion. Old man's lesion. Very good. Excellent, Abhishek. New generation spotters of my kind. The pelvis, bilateral pelvis showing something. Narrowed some space, causing some syndrome. Not really. Yeah. We'll discuss. Don't worry. Again, a kind of pain, fever, like stuff. Young boy, pain, fever. Very good, Abhishek. Abhishek is fast finger, yeah. Unfused epiphysis. Any specific name for this? Okay. One of my favorites. Without this, I won't go to exam. Favorites, yes. Yeah, we have reached 100 without much of an effort. Very good, excellent. So first one is neurofibroma. You got it right. Myelofibrosis, we got this one. Osteopetrosis, scurvy, we got this blade of grass sign, ischiofemoral impingement, spina ventosa. We got this little Liger's elbow. We got this angstpon. We got this talar OCD. So nothing much easy, no target sign in this. It's seen in T2. Easy. Okay, we'll skip this theory part to go read about it. Then this large spleen, enlarged liver, sclerotic bones, myelofibrosis, excellent. Right, you're right. All of you, you're right. And then Erlenmeyer fog deformity in a case of osteopetrosis, diaphyseal widening, classical osteopetrosis, bone within bone appearance. Then this was a relatively tougher one. People have answered scurvy, but you missed this beautiful sclerotic line, which you should have seen. This is a scurvy with osteopenia, metaphyseal band, and everything. Then this is a case of classical Paget's. Good. This is a case blade of grass sign. And this is a case of ischiofemoral impingement. See this? There is definite narrowed space. Normally the space is should be 2 centimeters or 1.5, 1.9 in standing. If less than 15, you should always think about ischio-femoral impingement. Very relatively MSK level, tougher spotter, I agree, but you should be knowing by now. So spina ventosa, metatarsals, so widening balloon-like appearance. So other thing is pyogenic osteomyelitis is the differential diagnosis. Okay, little leaguer's elbow. It is nothing but there will be clear medial elbow will be showing some avian changes or hyperintensity. So this is a little leaguer's elbow. AS sacroiliitis is seen, ossification is seen. Ossification dagger is not very classical, but other signs are also seen. Classical AS. Okay, then OCD, osteo. Always rule out an osteoid osteoma whenever you see a OCD of talus. That's a take-home point. Okay, again shoot. Let's see. Let's shoot again. Some ankle level spotters. We come down from head to toe. Shoot, shoot, shoot. Okay, this is a case of posterior tibial nerve schwannoma again. Okay. Clue. What is seen here? Plantar fasciitis. Okay, very good, excellent. This is what is happening. This is called paratendonitis. Achilles tendon doesn't have direct blood supply. It will have paratenon. Tenosynovitis you won't give in Achilles tendon. You get is paratenosynovitis. What is this accessory bone? What is this accessory bone? You are able to see here. Os. What os is this? Os trigonum. So os trigonum. So very good. So this is a complete collapse of the talus following large OCD. So this is a tibiofibular stenostosis with talocalcaneal collision. Okay. So this is again a what is any name of this fracture? Name of this fracture? This is called Shepherd's fracture. So this is called Shepherd's fracture. What is this complex? It's not a Bunchart lesion, take away. It's more of a congenital thing. Very good, Beaufort's complex. You know, absence of labrum with thickened MGHL is a Beaufort's complex. Air pockets are seen in what is this? Pyogenic osteomyelitis. Okay, these are the this is the last one was retrocalcaneal bursitis. This is the tendo Achilles. So these are the differential diagnosis. Okay, schwannoma. Then once again revision. 5 mm cutoff, plantar fasciitis, attachment. You also should know about Lederhouse disease or plantar fibromatosis. That is different altogether. Okay, and 4 mm on imaging. Paratendonitis, ostrigonum, subtalar osteoarthritis, then talar avian with subchondral collapse. So I told you that there are so many coalitions in this case. Shepherd's fracture, once again, Beaufort's complex, MGHL thickening, absent glenoid labrum. Then you have this gas gangrene and osteomyelitis, retrocalcaneal bursitis. Coming to last set, yeah, good 5 minutes, yeah, 5 to 10 minutes. You write down the you shoot in the box, yeah. Very good, excellent. Fluid levels, ABC. Fluid levels, ABC, good. Shoot. Very good, excellent. And also it is causing spinal glenoid. It's also causing compression, chronic compressive myelopathy, paralabral cyst or a spinoglenoid notch cyst, causing changes in the infraspinatus. Is the clue. Name of the syndrome. Shoot. Yeah, I agree. No. Yeah, Trishla is right. LSTV is also accepted. So, even I don't know the full form of it. Buttality is the name I have learned it. So there are types of it. And what is the shoot? Shoot. Shoot. Very good. Venous malformation or a hemangioma with phleboliths. Classical differential diagnosis of synovial osteochondromatosis. Like very good. Shoot. Excellent. Double PCL sign. Nothing. All bones are present. All bones are present or not? Fibula is present, absent fibula. Yeah. So this is a case of absent fibula with osteoarthritis. So surprisingly, the patient had absent fibula without any surgery or maybe previous traumatic resorption. Maybe a bit of fibula is seen here. I'm not sure about it. Okay. What is this? Actually, when I showed you the other case, you were shooting about that syndrome without knowing about that syndrome. What is this? What syndrome? Arrows are pointing at? Yeah. So this is the piriformis syndrome. This also I have discussed in length and breadth. There will be sciatic nerve involvement and perineuritis. This is valid sciatica. Patient will be presenting, they'll be writing discs, but the patient will have piriformis syndrome. Okay. All these things are important. So what is this pattern? What is this? Yeah, we'll discuss. This is again patellar dislocation with relocation with osteochondral loose body. PCL avulsion. Repeat. Okay. There's one OCD we have not discussed. This is what I was telling. This is the ABC, classical fluid levels. Differential diagnosis, always keep these differentials. You write it in the exams. And always look for the secondary signs, whether there is hyperintensity in the muscle, is the what is happening to nerve, and all those things you have to have a look at it. So this was my own case where when there is above the suprascapular nerve, there will be atrophy of both supra infra. If spinoglenoid lodge, as he was rightly pointing, there will be only atrophy of infraspinatus muscle. Okay. So this is a case of Bartoliti syndrome. There, she was telling at lumbosacral transitional vertebra LSTV. So that is what is important in a case of Bartoliti syndrome. There are types of it. You have to fit it into Castlevy classification. You have to know and you have to write about it. Ankle hemangioma, fluid levels so beautifully is there. Phleboliths are there. Synovial chondromatosis, you should not confuse it with. Okay, double PCL, classical, associated with ACL tears most of the time. When they can be intact ACL also sometimes. Medial meniscus characteristic bucket handle tear. PCL bucket handle tears also I have seen sometimes, but those are associated with ACL tears. Congenital fibular dysplasia or aplasia, piriformis syndrome, and osteochondral defect in this case, very small and tiny, very difficult one. Yeah. So this is osteochondral loose body in a transient patellar dislocation. What is TTTG angle? What is the normal TTTG angle? What is the normal trochlear depth? These are the things which normally everybody will ask. What is it? Yeah, normal 15 mm is observed trochlear depth. What is the sulcus angle? What is the sulcus angle? Yeah, absolutely right. That is one important. What is a normal patella? What is patella baja? What is patella baja? What is insult salvati index? Yeah, very good. Excellent. People are wonderful. You people are wonderful. So all these things you should be you should know, and you should be able to diagnose those things confidently. Yeah. So PCL avulsion, I already told, fragment and everything is important. Thank you very much. I was very happy interacting with you guys, and hope I was not fast and it was useful lecture for you. And I'm dropping my channel link here. YouTube. So there are more than 300 cases .com/radiology case videos. Okay, so you can just see some more cases. All right.
We'll post the link in the group also, sir. The
Yeah,
YouTube.
that's
Sir.
easier. I know it's
Yes,
not
yes,
coming this way.
sir.
Hope they had some lovely interaction,
Yes,
and
sir.
they were active until the last. That is what.
Yes, sir. Yes, sir.
Sure. Thank
So-
you. That was a
so
marathon
so-
session. Maybe time I was not knowing so much.
No, sir. Thank you so much, sir, for this wonderful session on the MSK spotters. And
Thank
your
you.
insights are really incredibly valuable, sir, for all of us, and they greatly enhance our understanding. And
Sure.
we truly appreciate the dedication and the effort you have put in the presentation. I'm
Sure.
sure the residents must have got enriched by your vast collection of cases.
Sure.
And with
Thank
this,
you.
sir, I'll seek your permission to close this session.
Sure. Thank you.
And
Thank you. Bye.
all the best, all the exam going residents.
Sure.
Good night, everyone.
Thank you. Thank you.